in the last few weeks, but for a while, we did not have a lot of mortality. The approach that was taken was that we needed to ensure that government activities are led from a sound scientific base of a group of researchers, scientists, clinicians who are at the back advising government, making forecasts and projections as to what the conduct of the epidemic is going to be, and using that to guide the activities of government. In the process, therefore, we have been making preparations for a situation where there will be a large number of cases admitted in hospitals, and our forecast indicated that the numbers that we might end up getting will be much more than the current capacity, and therefore we took a view that we need to take containment measures to flatten the curve. Out of that, we took an approach that there should be a proactive approach to go out and find out the cases, the positive cases, before they reach our hospitals, deal with them in time so that we don't have to wait for the avalanche to descend on our health facilities. Out of that process, government trained a lot of the health workers, primed them and prepared them to be able to go out. So we've deployed over 60,000 field workers who we call community health workers. These have been reinforced now by various other non-governmental organizations who are funded by PEPFAR and the Global Fund and other funders to help us to augment the program on the ground. At this point, 6 million people have been screened for symptoms and temperatures in communities where index cases have pointed contacts and other areas which are densely populated where we're very concerned about the spread of the infection. The infection has shifted from being imported cases to be largely internal transmission. In some areas, cluster outbreaks where you've got church meetings or shops or factories where a group of people get infected together. Out of this, we have actually tested at this point, a massive testing program has netted about 195,000 tests on individuals, of which the 5,000 are the ones who are positive. This gives us roughly something of about 3% positive rate, and we actually have to test about 40 people to get to the positive patients, to the positive case. That means to us we have to target a bit more on the case of so that we can find more targeted positive cases. We put out a lockdown, which basically is what has assisted quite a bit. The lockdown was to stop international travels. Ports of entries were closed. Large gatherings of churches, Easter church gatherings, sporting events, large meetings of more than 100 were stopped. Weddings, funerals were to reduce the numbers of people, and instituted the basic hygienes of cough hygiene, the hygiene on use of masks and distancing and hand sanitations all over the country, and encourage people to stay at home. The first 5 weeks has actually been proven to have assisted to deflect the exponential rise in the curve and deflect it to flatten a little bit. And in so saying, we are actually seeing a slightly different trajectory that has pushed the peak of the epidemic to around September in the best case scenario, or maybe July in the worst case scenario. And this is going to be related to how we ease off the lockdown, so that the president has called for a risk-adjusted easing of the lockdown to take into account the food security issues, to take into account the economic recovery that needs to be supported. All of this together, we're now working on the plans where we've actually looked at the country and we've broken it down into 5 stages of alertness, which means where we are now, where there's a lockdown, is stage 5, where there's high transmission, very low level of preparedness. We're moving to a stage 1 where there's a high level of preparedness and low risk of infection. And we are going to be demarcating all the districts to work out which one is suitable. So all of this together means to us that we have gained a bit of time, but I think our message has been important. to ensure that there's good information to the citizens, to ensure that there's one message for everyone, and that scientific research guides the response. It must be multidisciplinary, led by the leadership of the country, and that way we believe that we can make an impact. Obviously, the winter months are coming, but we are really hopeful that we have averted the first storm, but of course there's still a lot of time to go to see to what extent we're able to manage. So that is what we could share as our experience at the moment. Thank you.
Minister, thank you very much for that. And we have nearly 250 journalists from across the continent on the line right now. So I know there's a lot of people with questions wanting to find out more about your experiences, but they're also interested in other nations' experiences. And perhaps we can turn to Accra in Ghana, to an epidemiologist. Professor Karam, can you bring us up to speed on how Ghana is facing this pandemic?
Thank you very much. This is Professor Karam in Accra, and thanks for inviting me to be on the panel. Here, we started, I think our first case was second week or so of March, about March 12th, with 2 cases. And initially, all the cases were in travelers, as we had suspected. So at the very beginning, the very task of coordination, in fact, up till now, the task of coordination is being at the office of the president, and the president has made sure that he's up to speed on this. And to do that, he's appointed a national coordinator who happens to be Dr. Samaba, who was deputy director at the WHO. And he's also empaneled a group of scientists and others to help come up with various options and to guide the government. And at the very beginning, the decision was made to quarantine suspected individuals, especially travelers who were coming in, test them and isolate individual ones, isolate positive cases. And I think this was a good point, because at that point, we were not so sure what was happening. But for a group of about 1,000 or so travelers who the decision was taken to quarantine them and test them, we found that there were almost more than 10% were positive. The thing about this was that all of them were asymptomatic. So these would have been numbers which were going to be thrown into the population and infect or contribute to the transmission pool. So from that experience, the decision was taken that we should, as much as possible, track suspected cases, which would be contacts of people who've been to hospitals, and test as widely as possible. So the decision has always been to trace extensively, test as much as we can, and then isolate the positive cases, take them out of the population so that they don't contribute to the transmission. It's worked at the beginning, and to help with this, we had the stay-at-home or the lockdown for about 3 weeks, which also gave sort of free access to the people who were working on the ground, the Ghana Health Service and the Ministry of Health people, to contact people and try and bring in as many samples as we could. I think one of the things which helped us was that because of that, they were able to move and get in a lot of cases, but we also overestimated our testing capacity. So along the line, we became a bit overwhelmed, but we've managed to overcome that problem. And I think now we've done more than 110 or 120,000 tests. What it means is that instead of us waiting at the hospitals or the health facilities to get suspected cases who will be tested, we've actually gone into the population and tried to find out who are those carrying the virus, and then get them out from the population and reduce the transmission.
Yeah.
At the moment, from initial, I think the first 2 cases which were identified, the first number of cases were positive cases were 2 on 12 March. We've ramped up to a total of 1,671 positive cases. Unfortunately, we've lost about 16, which is just about 1% of the population. And then we've had about 190 recoveries. which means that after about 2 weeks or between 2 and 3 weeks, we don't find the viral RNA in their sample anymore. So we have 1,483 active cases which are still under observation. Some of them, most of them are at home or at isolation centers without symptoms. A few have symptoms and they are being managed at a couple of treatment centers. Yep. What we have found so far is that the majority of cases, I think more than almost 80%, are in Accra, a little bit in Kumasi, and then others scattered around the country. And even for those around the country, it's obvious that it's their contacts with Kumasi and Accra especially, which is contributing to those numbers. Because at the beginning, when the decision was taken to lock down Accra, some grace period was given, and within that grace period, a few people left Accra, and it happens that almost a sizable proportion of those who left Accra to other regions were carrying the virus. Their samples have been brought in, and they have turned positive, and they are the ones who have sort of seeded those places. So currently, the country is divided. The country has been divided into 4 zones. Based on the burden of cases and also what has happened. We have 16 regions. I think 4 regions haven't recorded any cases at all so far. Accra and Kumasi are the sort of the hot centers or the epicenters for the epidemic in the country. And then we have other regions falling in between these 2 extremes. The principle of tracing and testing as widely as possible still stays. And although the stay at home has been lifted from Accra and Kumasi, the other measures of wearing masks, reducing social or physical distancing in crowded places, and wearing masks in places, and avoiding crowding situations like churches, market. The markets are opened with some controls, but churches, funerals, our funerals tend to be very big crowd sources, and those have been limited to, I think funerals have been limited to maximum of 25 people, so small private burials. And then
Professor, thanks for that very detailed account of what's going on in Ghana. I know we've got around 250 people on the line who'd like to have a chance to put some questions to the panel, and so if I may, I just want to try and get to some of those journalists so that we can let them explore some of the issues that are top of their mind. But that was a very comprehensive and a very interesting account of the measures that you and your colleagues in Ghana have taken. So our thanks and appreciation for that. Can I turn to 2 journalists now, Paul Adepoju in Nigeria and also to Anu Adoye in South Africa, and just get their questions. But before turning to them, we have a question from Brian Pearson at Africa Confidential, who's asking Dr. Moeti, last week Tanzania was mentioned as an area of concern, and the question is that reports coming in are pointing to a serious problem in Dar. No figures have been released. How concerned is WHO about what's happening and the situation in Tanzania? But first, if I can turn to Paul and then to Anu, please. Paul.
Yeah, thank you very much for the introductions. And my first question goes to the Minister of Health for South Africa. South Africa and Ghana, they have roughly similar mortality rates, around 1%. And we have some other African countries around with 2 and 3%, but these are still very low figures compared to the rest of the world. So from your experience overseeing the response in South Africa and in Ghana, what do you think is directly responsible for Africa's low mortality rates regarding the COVID-19? And for Dr. Moeti, you mentioned the fact that several African countries are putting their political and economic risk into consideration while reopening these countries. But when the Minister of Health was talking, he mentioned the fact that the peak period for the pandemic in places like South Africa could be around July and September. As these African countries open up their economies, what is being done to ensure that at the peak of these pandemics, when the peak eventually happens, they are better prepared to respond?
Yep. We'll turn to Anu in a moment, but perhaps, Minister, Paul's question, you've carried out more tests than many other African countries and have a very low mortality rate. What are the principal lessons that you think South Africa has for other nations across the continent?
Well, thank you very much for the questions. I think the first issue to say is that I think for us in Africa, what would be useful is for us to go all out and use our health worker field operators to reach out and find people with suspicious symptoms, test them early before they are complicated, and then in the process, we could isolate them if they are found to be positive. That I think is going to be very helpful in reducing the numbers of people who will overwhelm our system. We also find that there are many people who are asymptomatic, particularly the younger people, and so it's important for us to always have a sense of the prevalence of the infection in the community. In relation to mortality, I think it's a bit early for us to explain what this would be, but we think that Africa largely has been behind the rest of the world in the onset of the outbreak. This might be a factor, so it might be early days for us. Secondly, we've noticed that some of the people are people who are younger, healthier, and therefore they tend to handle the infection a bit better. On most of the patients who have succumbed have got comorbidities, underlying cardiovascular diseases, pulmonary diseases, renal diseases, HIV and immunocompromised situations due to cancers. We think that this is a major factor, and the most of the people have also been above the age of 60. Particularly, we've seen the experience of what's happening in the world where the larger numbers of mortality comes from those who are from 60 to 70, 70 to 80, 80 and above. So we think that those are some of the issues. I think our preparedness needs to be focusing on creating more triage centers in every hospital, every clinic, so that people who walk into the clinic and hospital who have got symptoms, respiratory symptoms, must be separated from the rest of the patients in the hospital. And secondly, that we create field beds, field hospital beds, so that someone who is asymptomatic and does not need treatment but is still infective cannot go back to their communities where they are overcrowded and they cannot be isolated. They must be kept for the 2 weeks until we have the treatment. At the moment, we've got very few people on ICU, about 30 of them, and about 15 are on ventilators. So most of the people who are possible to isolate at home are being treated at home because of the ability to contain the infection from infecting other people. So I think we have to learn as we go, but very strong case management from our clinicians is one of the major issues, and protection of our staff from getting infection. Thank you.
Thank you, Minister. Dr. Moeti, if I can turn to you on the questions from Paul, and perhaps also to touch on the question from Brian Pearson on Tanzania.
Yes, thank you very much. I think I can say generally, before talking about Tanzania specifically, that we are observing countries taking an approach to the response at different speeds. So different aspects of the measures that need to be put in place to prevent transmission at different speeds. And the main measures, as we are talking about now, include identifying cases, contact tracing, isolating the cases, quarantining people where necessary, and then in addition to that, the physical distancing measures that have been put in place more broadly, either in cities or in countries. And what we have observed, for example, is that Tanzania took some time to implement, particularly the physical distancing measures, such as while schools were closed, places of worship were kept open, so that gathering of people continued to happen in closed spaces, as well as, of course, in shopping areas and in markets, which is an aspect of our countries that we have seen has been very difficult to impose in the way that people generally shop and the way areas where people shop in many African countries are organized. In addition to that, after Dar es Salaam was recognized as having, if you like, being the epicenter, the prevention of travel from this epicenter also took some time to happen, which means I think the minister, no, the professor from Ghana said when the country announced that Accra was being locked down, there was a grace period in which people traveled out of the city and therefore managed to spread somewhat the virus around. So this, we believe, was happening in Tanzania. In addition, we have observed and have had reports from neighboring countries that truck drivers, people who are traveling by road carrying cargo from across Tanzania, have been found in a number of the neighboring countries to be positive. So in my view, and we are working with, we continue through our country team and working with technical partners on the ground to advise the government, to provide them with the knowledge that WHO has, with the guidelines that we have, and with the experience from other countries, in order to have those policy decisions taken based on data that will enable the government to get on top of the situation and to hopefully start to see a bending of the curve that is happening at the moment.
Just a follow-up question from Alphonse Shundu of Africa Check in Kenya, directed to Professor Koram in Accra, Ghana. Alphonse Shundu asks, he says, Tanzania's president asked his Ministry of Health to recommend the use of steam inhalation to combat the coronavirus. As an epidemiologist, what's your experience in providing scientific advice to political leaders? And what's the best way that political leaders can communicate with their populations when it comes to offering advice on the pandemic? And could you briefly tell us, your opinion on that particular advice?
Well, for me and for probably those I've been working with, you work from the position of strength, what you know, and you try to make sure that your recommendations or your suggestions are based by what is known. So some of the treatment, for example, which are all over the place, the advice has been that we need to collect the data, we need to see what is true or what is not true in our populations, and also guide on that. What we realized from the very beginning is that you cannot, for example, if based on the epidemiology, you said, okay, let's lock down the place, let's contain everybody, track everybody and things. It's sound. But if you are in a position, if you're in a place like Accra, where there's a large majority of, let me put it, people in the informal sector, for example, then that advice has to be weighed on or has to be taken in addition to what will happen to that population, which probably have to go out on a daily basis to get their daily bread. And so you can make your pure, let me put them, pure scientific advice, but you have to be aware that it has to be managed in the context of all the other things. And I think that is where those who have to take the decision, the ministers, the president and things, really have a tough job on their hands. Because, for example, in Accra, we were all expecting that after 3 weeks, we'll probably have another 3 weeks. But the argument from the other side in terms of people's livelihoods and things seems to have outweighed the scientific or the pure scientific advice that we were putting down. And what it has meant is that, okay, let us slowly get in and see what we can do. But within that, then we have to calibrate our advice, because we had a pure thing, lock everything down. Now the thing has been, okay, we have to release a little bit. So we go back and then says, okay, given that this has been done, what is the best thing that we could do and things like that. So it's sort of, we're all learning. And I think I mentioned to a colleague yesterday that this whole thing is more like a black box to everybody. You decide to lock down, based on one or two things. There is no discussion as to what will happen before you unlock and things like that. But we have to learn as we go along, and also be very much aware that the advice to those who have to take the decision is not entirely based on what you say or what you don't say.
Just turning back to Anu Adoye from Mail and Guardian South Africa, and also if we can go to the question from Inga Sabia as well. Anu first.
Thank you very much. Anu Adoye from Mail and Guardian in South Africa. My question is to Dr. Mkhize. So now that South Africa is entering a new phase tomorrow, where the economy is being slowly reopened, I'm wondering what the new models are in terms of transmission rates. What is the government looking at so that the cases don't spiral out of control? And what are the plans to further ramp up testing now that there's about 1.5 million people emerging from their homes from tomorrow? Thank you.
Thank you. And Inga Sabia. If we can turn to Inga. Yep.
Hi, can you hear me?
Go ahead.
My question is also for Dr. Mkhize, and I was just wondering, now that we are easing the lockdown in phases, what is your metric of measurement to decide how we move from one phase to the next? Is it percentage of infections or people cured, or is there a specific number that you're looking at?
Thank you. Minister, can I turn to you for some answers on those key questions?
Thank you very much for the questions. Let me start by explaining that the lifting of the lockdown was mainly due to the scientific focus that indicated to us that the 5 weeks that we have will give us a maximal shift in the curve, in the peaking of the curve, that if we were to move the lockdown further by another month or 2 months, it would hardly change that trajectory, which therefore means that for us, we do accept that this is the time for us to lift the lockdown. The phasing of the lockdown has to take into account two major issues. The first of those is the rate of transmission of the virus in that particular area. The second one is the readiness of the health services to respond to the burden of the positive patients in the particular area. This then means that every part of the country has got a different rating that we're going to be assessing them into. And out of that, the metro areas are the ones that were concerned that there are very high transmission rate. They are the high transmission rate areas, and therefore we have to balance the extent to which we're going to ease off certain restrictions vis-a-vis the need for us to contain the spread of the infection. So when we talk about returning to a phase, risk-adjusted return to normality, it means that we are going to start from areas where there's a high transmission rate and high level of a poorest level of preparedness of the system. Anywhere where there's such a situation, we will therefore not ease economic activities and social activities that much. But slowly, as we build up our capacity to respond, we'll then find that it's easier to open up slowly into various other areas. So, for example, some of the areas had a huge rise in the rate of the infection, such in the area of Mangaung. In the past 3 weeks, they've been able to stall that rate to a very few numbers of cases, which means that their level of response and level of transmission has shifted from being very high to being moderate, and therefore it allows a different response to that than if you were to compare to a Cape Town, where the rate of transmission is very high, still rising, and the numbers of beds that we have, the numbers of staff that we have, the numbers of tests that we have to do have to be pushed to a level where it can match to be able to start containing the rise of the numbers of infected people. So the balance is going to be on a case by case, district by district, area by area, and therefore we're going to be balancing out of these 5 alert areas that you have indicated. Thank you.
Thank you very much. We have a couple of questions on COVID-19 in conflict zones, particularly DRC, Libya, Somalia, but especially Burkina Faso. And I wondered, Dr. Moeti, if there's any information that you and perhaps Dr. Yao can add on the situation there. And just a reminder, pour nos auditeurs francophones, on peut poser des questions en français aussi. Dr. Moeti.
Yes, thank you. I think just to say before I invite Dr. Yao to comment specifically on the situations, that we're very, very concerned about the vulnerability of people living under conflict conditions, people living in refugee camps, people who have migrants, they're living in very precarious situations, which is the case in some of the Sahel countries, in places like Central African Republic, in South Sudan, and so on. And we are working there with the humanitarian partners as well as with the governments to support the response, in this case, mainly in trying to prevent the virus getting into these communities, some of which are in remote areas where perhaps the virus, the way it has traveled through the African region, may not have reached, but it's a big concern for us. Michel, est-ce que tu peux dire quelque chose concernant ça, s'il te plaît?
Yeah, thank you very much. About the conflict area, the main challenge is access. And we recall what happened in Eastern Congo with Ebola, where access is a critical element for a team on the ground to structure the response, mainly the surveillance component, as well as setting up also facilities for testing and treatment. So this is our major challenge. And as mentioned by Dr. Moeti, it's where partnership is required, working closely with all the humanitarian partners to assess these areas. And in most of the cases, in the case of COVID, these are areas that are a bit far from the capital city, and is where decentralization of some of the capacities, including testing, should also take place. And in these countries, WHO offices are working closely with related agencies, including IOM, as well as the UNHCR, to address these challenges.
Thank you, Dr. Yao. Question from Neil Munshi at the Financial Times in Nigeria. And perhaps I can put this question first to the Minister. Neil asks, how will the focus of resources and attention on COVID-19 affect the fight against other diseases that health ministries and governments are trying to tackle? Do you expect an uptick or fresh outbreaks in other disease areas? Minister, your approach on COVID-19 has been pointed to as notably successful. Is that coming at the cost of tackling other diseases?
Well, thank you. I think it's a very interesting question because we grapple with that matter every day. The reality is that we have to mount an immediate response to the COVID-19 challenge, but at the same time, we do understand that unless our health services are able to balance up in the management of the other comorbidities, then we have a challenge. A huge number of our people who are having diabetes, hypertension, chest infections, tuberculosis, HIV and AIDS and cancers. All of these need to be managed as well whilst we're dealing with this. That is the reason why there's been an additional allocation of resources to actually help the department to get additional human resources, additional structures in terms of hospital beds and additional hospitals, like field hospitals, so that we don't actually have the COVID-19 patients displacing other patients who are quite needy. and also that we're going to end up with a situation where the triage at the entry of the hospital must allow people to continue to be treated for other conditions, whilst at the same time we have to manage the rising tide on the COVID-19 infections. So we have to keep a balance because in our case we're concerned about over 5 million people are on antiretroviral treatment. They cannot get off that treatment, and they cannot be, their treatment program cannot be undermined because that's going to create a new problem on the side. Then as a result of that, therefore, we have encouraged or empowered our community health workers to continue the messaging. It's important to take your treatment. It's important to go and seek your treatment, your attention at the hospitals early. But at the same time, we have to keep the balance so that people must know you can't you can't prevent a death from COVID-19 and still die of diabetes, die of HIV or pulmonary tuberculosis and so on. So it's a very difficult balance, but we have to try and manage it. Thank you.
Dr. Moeti, you've mentioned before that the fight against Ebola is ongoing. Have you seen across the continent a rise or problems in addressing other disease issues? And there's also follow-up from the Associated Press regarding Burkina Faso. They say that there are reports of increased cases of respiratory disease, and without testing, how can health authorities and health organizations be sure that these are not, for example, cases of coronavirus?
Okay, I think first of all, with regard to other diseases, yes, we already at the start of this COVID-19 pandemic, there were a number of outbreaks going on in a number of countries, measles outbreaks, cholera outbreaks, as well as outbreaks of vaccine-derived poliovirus type 2, that countries were being supported by WHO to.
We're just struggling with the line there in Brazzaville.
We have seen developed.
I don't know if we're going to be able to hear Dr. Moeti at the moment. Perhaps Dr. Yao, we have a slightly better line into you. Can we just turn to you for a moment just to ask about that question about the struggle against other disease and the situation without testing? How do health authorities know what's really going on? And we'll try and get the line back with Moeti.
Thank you very much. The other conditions is critical in the African context to ensure that we have a continuity of the different services. So in this line is what is also mentioned by the Honorable Minister, is to ensure that we have a proper triage that keep on one side this service ongoing, as well as on the other side the COVID channel, and to ensure that also health workers can be also repurposed in a way that we keep these services ongoing. We ensure also supply chain in a context where we have also the lockdown that can affect supply for other disease. Is why it's a multi-sectorial approach that needs to be in place to ensure that this service continuity is done in most of the countries. In a context where we have less testing, the other additional advice is not the best, is also to rely on what we call case definition. Relying on symptoms while we have a positive case in a given area, we can rely then on symptoms to take appropriate control measures. It is done in many other outbreaks, in cholera, for example, where in the past we were not able to test everybody. We just confirm few cases and rely on case definition to do so. While we are trying to also do our best to support countries, we are trying to trigger a wider solidarity, because testing help actually to anticipate, to have also early detection that give a better outcome in the treatment. Thank you.
Thank you for that. And perhaps I can just briefly turn to Dr. Coram in Ghana. Dr. Coram, just some perspective. We hearing from journalists across the continent that about reports on respiratory problems in camps and in areas where it's very difficult for health professionals and health organizations to access. In this situation, what can be done? What real options are there? Is it simply the case that we have to sit back and observe, or are there more concrete steps that you would be advising governments and organizations to take?
That's a bit a tough one, in the sense that if they're difficult to reach areas, then some of the known things that we do may not work, and we may have to start looking at other issues that we can bring on board. But it comes up to something that I think Dr. Yao mentioned, that as much as possible, if we can try and get a handle on not all the cases, but a few of them, and have an idea what is going on, then we can make some assumptions and go ahead with the best possible guesses. And this brings me back to my early days when I was working in the CSM belt in the north of Ghana. And at the beginning, we were doing LPs, although we couldn't do much in terms of microbiology. Just the nature of the CSF could tell us whether it's turbid or clear, then we could see that we had a problem. And I remember clearly one morning when we reviewed what had happened the previous day, and out of about 27 or so LPs that had been done across the day, I think 23 or 22 of them, everybody had reported cloudy. And we were like, look, we had an epidemic on our hands, so let's just get on to it. Anybody who comes with symptoms in that manner, we will treat. So I think we will make the best of what the situation that we get, and it may not be easy, but possibly we could get a hand on a few of those cases and then give their advice accordingly.
Thank you, Professor. Turning to Stuart Spear from FII magazine with a question. Stuart Spear.
Yes, thank you very much. It's a question for Professor Coram, and I'm interested to find out what has Africa's experience with Ebola taught us about how to try to best control COVID-19, and how is this knowledge being applied?
Professor.
Yeah, thank you again. And I mean, on the level, or at the level that this is also something that we've not met before and sort of throws out everything that we know, maybe then the similarities between Ebola and COVID, you talk about that. But beyond that, we have clearly two different issues here. Ebola is highly, lethal, but the transmission is such that the isolation and things would work far better in that state, and we could manage that in terms of isolating patients and things. What we learned about what we should bring from Ebola is this whole idea about sort of people not being aware clearly as to what is happening. So when you isolate somebody, and especially when people are with Ebola, people are more likely to die from the isolation centers than with COVID. We need to be clear and communicate that right from the beginning, the reasons why we're doing isolation, we're doing quarantine and things, and people not to be afraid that something untoward is going to happen in those situations. For me in particular, and in Ghana especially, I think that has worked to a large extent, where along the line, we got some of those who were isolated very early on in, I think, Tema, to come to one of the press conferences of the ministry and to say that, look, I've been in there for 2 weeks, and the reasons why I went in was that I had symptoms. I couldn't breathe well, and they took care of me, and I'm back here and I'm normal like anybody else, which I think has helped in terms of getting people who are positive to get into the area. One other area which I think was very important was the ability of countries to be able to test their samples. And I think that lesson was learned quite well, so that you see in COVID-19, almost every country has at least some testing capacity. It's not enough, but I think we're learning that we need to expand that. Just before I end, briefly, as we release some of the restrictions in the country, the decision has been taken to actually expand the testing sites and also the isolation sites across the country to help in terms of not overwhelming the health system and other issues that we have to deal with. We've also identified treatment centers so that not all the hospitals are going to treat, but the triaging and things will have to be done in every facility. But if you have a case, then we'll take to a place where we have trained people who will take care of them and things. So maybe I'll end that here.
Thank you, Professor. I have a question from SABC News from Arabile Gumede for the Minister. Minister, the question is, are there any projections on where the death toll in South Africa might be when infection reaches a peak in September? Is that something that your department has been looking at?
Well, we have not publicized any forecast of deaths as such. We've just issued a general awareness that if we don't manage to reduce the numbers of cases, that the death toll might increase, and therefore we will go on to make preparations for that. We have a number of focus groups that are working on this matter, and in the process you realize that their figures are varied, so we've avoided publishing figures because they can also be misused for sensational purposes, and so we don't have a figure that we are specifically working on, but we keep improving our focus model as we improve the data coming from our test sites. So we will only be certain that any forecast is correct when the numbers that we have fed in have actually been in place for a while, and we observe the changing pattern of the epidemic. We actually believe that the numbers that are going to be coming in the beginning of winter, when the co-infection with influenza viruses is going to give us a better sense as to whether we're going to look at a much more pessimistic scenario where there'll be a much more rapid rise in the numbers of people who are infected and therefore demising, or it's going to be possible to manage it until we can get the peak later on in September. So we are going to be preparing for any eventuality, but we are avoiding issuing numbers out because if you looked at the first forecast, we would have actually been at a much higher level, but the interventions did change the course. So we believe that whatever forecast may be, we must work for the best scenario possible, even though we've got a sense of how bad things can be. Thank you.
Thank you, Minister. We're running out of time on the call, and apologies to everyone who's waiting to speak. We have time, I think, for one very brief final question, going to Janice Q from Bloomberg Live. Janice, can you deliver your question, please? We're going to have to try and get your audio to work to hear your question.
Is that better?
That's better. We can hear you.
Great. I was just saying South Africa's been moving to universal healthcare for a few years. And I was wondering how closely the private healthcare sector has been working with the public sector. Do you think, Dr. Mkhize, that the response to the outbreak in South Africa has broken down some walls where moving to NHI will become easier?
Minister.
Well, thank you very much. Very interesting question, because indeed, we have actually all agreed that to face the COVID outbreak, we need to face it as South Africa as a health sector, which means we don't make a distinction between private and public. So already, for example, the first few cases that came through were actually diagnosed by private sector. They were admitted in the private hospitals. and the testing also happened initially in the public sector, later in the private sector. So there's a huge collaboration with the laboratories. At any one time, if there's any backlog in any one of the laboratories, the government can step in and take over the specimens, do the tests, and make sure that there's no backlog as such. We can put a message at any one time and talk to all the CEOs and correct whatever problems between the laboratories. In the private sector, we have actually sat down, compared the numbers of beds. We are agreeing that we're going to share the burden, and at the moment we are negotiating the terms of engagement so that where there's facilities in the private sector, we'll use them and there's no problem. We're now looking at the discussion with the general practitioners to see that now that there's going to be a need for us to focus on community health, can we actually start engaging the general practitioners? So I think the COVID-19 will make the collaboration much closer between public and private. As to the attitudes for the universal health coverage, I think it's something that we have still to work on. I believe that a lot more would have been achieved when we get out of the COVID-19 outbreak response than we have been before. But it does require still a lot of engagement, because the interest in the public and private sector can never be aligned completely. But if we can actually find a mechanism where we can coexist in a model that allows us to be able to settle each other's concerns, we will actually be much closer to the universal health coverage. Thank you.
Minister, thank you very much. We're running out of time on today's call, but I very quickly want to turn to Dr. Moeti in Brazzaville just for some final observations on where we stand this week across Africa.
Yes, thank you very much. In terms of the situation in Africa, we are continuing to see an increase in cases. I think our outbreak is continuing. We have now confirmed 23,800 and so cases and 933 deaths in the region. And then in the continent, including North Africa, 34,610 cases. We are seeing case fatality rate in the region of about 3.9%. We have a couple of countries that have a higher case fatality rate. What is very encouraging, and I'd just like to emphasize this, is that we have a number of countries that have reported 0 cases over a couple of weeks. So these are admittedly relatively small countries, Namibia, Mauritania, and Seychelles. But they put in place as well some measures, early measures, starting with testing, contact tracing, which have produced some results. And then we are very concerned about West Africa, where we are seeing community spread in a significant number of countries compared to others. We are working with the UN in West Africa, particularly to see how to support that. And then to conclude on the matter that we were discussing today, I'd just like to say that, and it came out very well in the observations and the information shared by the minister and the professor, that these are not easy decisions at the political and policy level to make. There is always a need to balance, and we have heard in the conversations, not only in Africa, but in Western countries worldwide, that deciding to put in place these measures, deciding when and how to lift these measures is extremely challenging. There is always a need to balance. We encourage very much the use of data, so that when a government decides not to lock down a city, they need to be aware that there will be consequences in terms of the spread of the virus. And we hope that these decisions are made having taken into account overall the balance between enabling economies to continue to grow and stopping the spread of a pandemic that can have profound long-term impact on the economy. So this is how I'd like to conclude, recognizing those challenges in making tough decisions. Unfortunately, this is where we are worldwide. Thank you.
Thank you, Dr. Moeti. And from us on this WHO call, it just remains for me to thank everyone for joining, to thank the Minister in Johannesburg, to thank Drs. Moeti and Yao, and to thank Professor Karam in Accra, Ghana. Thanks to all of you for joining. Sorry we couldn't get to every single question that we had. We will return next week with more on the situation from Geneva. Goodbye.